All right, looks like we're getting close to the 7 a.m. time. Brian, I'm still counting up here. How are we
We
looking?
do, we do have a quorum.
Excellent. Well, since we're at 7 o'clock and with a quorum, I'll call this meeting to order. So welcome everyone to the May meeting for our P&T committee meeting. And our first item on the agenda will be to review and approve the minutes from our last meeting in February. And those were sent out in Brian's email.
I move to approve.
I'll second that. Okay. All in favor, say aye.
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 All opposed? And any abstentions? So those minutes
Just a
are
quick
approved.
reminder.
Oh, yeah.
Just a quick reminder before we move on. If you're on the call, please let us know either in the meeting chat or by email at medicaidpharmacy@utah.gov your name and your affiliation, and please keep yourself muted unless you're speaking. And if you're joining by telephone, please email us at medicaidpharmacy@utah.gov to let us know who you are so we can keep track of attendees.
Thank you for that reminder. And I believe that was the only housekeeping item we had on the agenda for this meeting. So we'll move on with Dr. Nguyen and the DUR board update.
Good morning. So the DUR board has met in April to review the guideline treatment recommendation for the non-specific low back pain with or without radiculopathy. And then we met last week to review the Tezspire or tezepelumab to establish the PA criteria. The board also reviewed the HETLIOS PA criteria. The board will meet in June to review pediatric insomnia, and July to review adult insomnia. We will keep the P&T updated. Thank you.
Excellent. And Brian, do we have Dr. Heath doing the review next, or this ACO update report? Should we do that before the?
Yeah, so it's the annual updates from our accountable care organization partners, and so
That's right. Okay,
go to that next.
Yeah, so we'll have Dr. Goodrich from Molina, if you're on the call.
I'm here. Sorry, it took me a minute to get off mute. And then I think I emailed you guys my slides. Did you want me to present, or will you guys be bringing up the slides?
I have those and I can present if you'd like.
Sure, that'd be great. Thank you.
All right. Just a second while I pull those up.
Here we go. Thank you. All right.
You're
So my
welcome.
name is Heidi Goodrich. I'm the pharmacist manager for Utah and Idaho with Molina Healthcare, and I'll be presenting our preferred drug list strategy today. Next slide, please. All right. Molina Healthcare is a Fortune 500 company. We offer managed healthcare services under the Medicaid, Medicare, and the state insurance marketplace programs. We have 5 million covered lives across 19 states. We have a National Pharmacy and Therapeutics Committee that is the governing body for all of our drug-related activities across the company. Our voting membership are external providers within our Molina networks. We have 11 members, and that membership is a mixture of both pharmacists and physicians who have a wide variety of backgrounds and specialties. They meet once a quarter and they report into our National Quality Improvement Committee as well. And then we have kind of 3 different subcommittees that kind of feed into our National P&T Committee and give recommendations for the benefit, which includes the Molina Policy Voting Committee, and there's a state representation for these pre-P&T activities. We also have our DUR board, and that reviews utilization trends across all of our states, and then also our PA Core Committee that it reviews and updates all the drug criteria at least annually. Next slide, please. And then this slide kind of shows the 3 main functions of our P&T committee. First being that they develop and maintain the drug formularies. As you can see, Utah follows the Molina 1 formulary where the states are allowed to have more control over their formulary in the other states. That includes, and then also we have a marketplace formulary and then our states that follow their respective state PDL. Second, they review and approve utilization management, which includes any edits such as prior authorizations, step therapy, quantity limits, generic substitutions, quality monitoring indicators, and then also the DR program and board oversight. And then finally, they evaluate our policies and procedures and also educate providers. And so they will review our drug criteria, products usage, and the P&T committee decisions. Next slide, please. And then our preferred drug list covers a wide variety of drugs that treats many different diseases and medical conditions. We have 2 tiers, tier 1 being our preferred generic drugs, and then tier 2 being the preferred brand drugs that include specialty drugs. And then we use various utilization controls on the preferred drug list, and this list will indicate these utilization controls, which include step therapy, age and quantity limits, prior authorization, generic drugs with therapeutic equivalents to the brand name drug, and then opioid edits that follow the state MME daily limits. Next slide, please. And then this slide basically shows all the many different factors that go into our decisions for coverage on our preferred drug list. First being that it has to be a covered benefit per Utah Medicaid and CMS rules. Our strategy also follows the FDA approved indications and dosage limits, safety and reported adverse events, quality treatment that's supported by national guidelines for practice standards and accepted by the medical community. They have to show efficacy compared to our non-formulary drugs. We consider the drug utilization trends of clinically similar medications, the branded generic pipeline, and then potential economic value for net cost and market share. And we also consider the federal Medicaid drug rebate program, and then most importantly, the potential impact on our members. And that concludes my presentation for the day. Any questions? All right, thank you.
Thank you, Dr. Goodrich. And next up, we have Dr. Mitchell from Select Health.
Good morning, Matt Mitchell, Executive Director of Pharmacy for Select Health. Select Health is a not-for-profit organization. It's part of the integrated system with Intermountain Healthcare. Select Health, and Intermountain work together with shared clinical integration, clinical programs, and patient initiatives. These programs and initiatives continue to provide patients high-quality healthcare, as demonstrated with our commitment to the community to help people live the healthiest lives possible. In working with collaboration, Select Health and Intermountain Healthcare had developed and implemented clinical work groups and clinical programs. Some examples include asthma, diabetes, hypertension, and pain. These care process models are reviewed and updated regularly. Select Health has its own P&T committee, which meets monthly. The committee is comprised of local physicians and pharmacists with a variety of specialties. Based on our knowledge and experience, physicians and pharmacists provide insight to local healthcare trends and understanding how the decisions impact their patients. As required, Select Health covers the medications listed in the PDL Plus file from the state. All new drugs approved are reviewed within about 90 days, and most of them are reviewed within 30 days. A variety of factors are considered, such as clinical efficacy, safety, any special considerations like dosage forms, special handling, and that kind of thing. is considered, such as prior authorization, quantity limits, and each category is reviewed at least annually, such as hyperlipidemia, asthma, COPD, opioids, endocrine, all the major ones, just like every other plan. Any questions for me?
Sounding like there are none. Thank you.
Thank you.
Next, we have Dr. Tran from Health Choice.
Hi, this is San from Health Choice. I'm a pharmacist. Can everyone hear me okay? Did you
Yes.
have slides for my health plan, or should I present them myself?
I have them. Just a second. I'll present that for you.
Great, thank you so much. All right. Again, my name is San. I'm a pharmacist with Health Choice Utah, and I'll be presenting the preferred drug list methodology for Health Choice Utah. Next slide, please. When we are developing and revising our PDL, we take a lot of input, including looking at the PDL Plus file from the state, as well as getting input from our P&T committee, other providers, pharmacists, medical management committees to develop our PDL. On a regular basis, we do also look at new drug entities that are coming out, new formulations of existing drugs, and new indications for already existing drugs in the market. Next slide, please. We do have a public-facing PDL searchable formulary that is on our website, and that is our website right there in the blue link. And the way our drugs are categorized, whether it's preferred, non-preferred, we looked if it's carved out and not covered. And when we are looking on our website, you can also find that there are forms and step therapy documents also available in public-facing way for our members, our providers, and as well as within our entity. When we make changes to our PDL, we try as much as possible to be very transparent and communicate with our providers as well as our members. So whether that be sending them letters or including that in our provider newsletter or sending them letters via fax. Next slide, please. When looking at prior authorizations and how we develop our criterias, these are mainly written by pharmacists and physician input. We take into consideration literature that's available, guidelines. We also talk to medical specialists in a particular field if it pertains to their specialty. We look at input from our PBM, as well as our manufacturer relations teams if they do present to our health plan and get their input as well as look at pharmacoeconomic data. We take our recommended criteria, and we send it to P&T for review and approval. Medications that are not included on the PDL do require a PA for approval for coverage. The PAs that are used to direct drug therapy to the most clinical and most cost-effective drug product available on the PDL. So we really try to drive towards anything that's effective and cost-effective. And overall, we do PA reviews to ensure that our members are receiving clinically appropriate care. Next slide, please. So just expanding on our P&T committee overall, we do have 4 physicians and 2 pharmacists on our P&T committee. The idea is to supply multidisciplinary input from these different fields from their standpoint while we are reviewing and considering these criteria and moving it forward to approval or recommendations to modify what we have recommended for them. We want to promote clinically appropriate drug use as well as positive member outcomes. So their input is very important to us. As well as they also determine formulary inclusion. Again, making that approval whether or not to include on a formulary or not. Recommendations, again, are presented to the P&T committee. We look at efficacy, safety, cost effectiveness for our consideration on adding it to our formulary. And when a medication is released to the market, we try to look at that within 180 days of market release. And next slide, please. And I think that is all I had for Health Choice Utah. What questions do you have for me? All right, thank you so much. You have a good rest of your morning.
Thank you. And next from HealthyU, we have Dr. Gilreath.
Hi, good morning. My name is Shannon Gilreath. I'm the clinical pharmacy manager with HealthyU. And Brian, I don't think you have my slides. I have them up ready to present.
I don't have yours, so if you could
Okay.
present them, that would be great.
Perfect. Okay, so does everybody see? Here we go. They're loading up. Okay, so the University of Utah Health Plans, HealthyU formulary methodology. Our HealthyU reviews new drugs, dosage forms, excuse me, and or new indications weekly. Recommendations for formulary inclusions are compiled to present to the University of Utah Health Plans P&T committee on a quarterly basis. We regularly consult the state PDL Plus file and our contract with the state before making coverage recommendations. Formulary inclusion is determined by the University of Utah P&T committee. The committee is comprised of university and outside primary care and specialty physicians, pharmacists, and nurses, and meets at least quarterly. The P&T committee is responsible for developing, managing, updating, and administering the formulary. Formulary determinations are based on the most current clinical trials, treatment guidelines, pharmacoeconomic studies, FDA-approved prescribing information, safety data, utilization data, and or other outcomes data. Clinical trials and clinical guidelines are considered when they are evidence-based, peer-reviewed, and relevant to clinical practice. Pharmacoeconomic data includes total cost of care, including drug cost, administration fees, and other healthcare expenditures related to the treatment in question. The committee considers the therapeutic advantages in terms of efficacy and safety in determining addition for formulary. The P&T committee makes a reasonable effort to review a new FDA-approved drug product or a new indication within 90 days of its release onto the market. The committee makes a decision on each new FDA-approved drug product or new indication within 180 days of its release onto the market, or a clinical justification will be provided if this time frame is not met. Additionally, each therapeutic class is updated as needed and reviewed at least annually. The formulary is dynamic and continually revised. It is posted real time on the HealthyU website and is updated whenever changes are made. Any negative changes to the formulary are communicated to the effective members as per the designated contractual timeframe. Significant changes to the HealthyU formulary are communicated to providers through our provider relations newsletters. Our drug utilization processes and protocols, as administered by the DUR board, are reviewed and approved by the P&T committee. This includes edits such as prior auth, step therapy, and quantity limits. The DUR board also drafts medication use policies for review and approval by the P&T committee. Our medication use policies or prior auth criteria are reviewed and approved by the P&T committee as well as the medical policy committee as needed. PA criteria is based on medical necessity, evidence-based medicine, and pharmacoeconomics. Prior authorization requirements are posted online. And as an integrated healthcare system, we also regularly consult with subject matter experts from the university before, during, and after the P&T process to assure that our criteria and coverage determinations do not conflict with current prescribing practices. There is a PA process for certain high-risk, high-dollar medications as well as non-preferred drugs. All Medicaid-covered medications are accessible to members through this process. We also have a formal appeals process in place for members or providers who disagree with coverage determinations. The HealthyU's formulary is in compliance with the ACA Section 1557 regarding the prohibition of discrimination based on race, color, national origin, sex, age, or disability, as well as other components of the ACA regarding essential health benefits. Thank you. Can I take any questions?
All right. Thank you very much, Dr. Gilreath. And not hearing any questions, I think we'll move on to our next agenda item, which is the review of colony stimulating factors from Dr. Lauren Heath.
Good morning, everyone. Let me just share my slides. All right, please let me know if you can't see the slides. I think they're coming up now. So today I will be presenting a summary of our drug class review on colony stimulating factors. Please refer to the full report for details. Recombinant human colony stimulating factors, abbreviated CSF, are hematopoietic growth factors that stimulate the production and differentiation of progenitor cells in the bone marrow and enhance the function of lineage-specific developed cells. Granulocyte colony stimulating factors, abbreviated GCSFs, are selectively targeting neutrophils, whereas granulocyte macrophage CSF, abbreviated GM-CSF, stimulates production of neutrophils as well as macrophages and myeloid-derived dendritic cells. Biosimilars are products that have demonstrated sufficient evidence to be considered lacking any meaningful differences in efficacy or safety compared to the reference or originator product. None of the CSF biosimilars are considered interchangeable with the originator by the FDA. There are 5 short-acting GCSFs that typically require daily or twice-daily administration. These are filgrastim-based products, the originator, Neupogen, and its 3 biosimilars, and TBO filgrastim. While TBO filgrastim is similar to originator filgrastim, it is not an FDA-approved biosimilar. It was approved prior to the biosimilar regulatory pathway in the US, yet it is approved as a biosimilar to filgrastim in other countries. There are 5 pegfilgrastim-based products, which are long-acting GCSFs with the same mechanism of action as the short-acting GCSFs, but that are given less frequently, for example, only once per chemotherapy cycle instead of daily. These products include originator pegfilgrastim or Neulasta and its 4 biosimilars. Only originator pegfilgrastim is available for use with an on-body injector that is to be applied by a healthcare provider and automatically delivers the pegfilgrastim dose about 27 hours after placement. Sargramostim, as the originator leukine, is the only FDA-approved GM-CSF. It is a short-acting product administered daily. Both sargramostim and most filgrastim-based products, except TBO-filgrastim, can be given subcutaneously or intravenously, depending on indication and preference. TBO-filgrastim and pegfilgrastim-based products are only for subcutaneous use. When possible, guidelines prefer the subcutaneous route of administration. These next slides show the FDA-approved indications for CSFs. Filgrastim and sargramostim have the most FDA-approved indications at 6 each. An indication shared by all G-CSFs is to reduce neutropenic sequelae among patients with non-myeloid malignancies such as solid tumors or lymphoma receiving highly myelosuppressive chemotherapy. The only other approved indication for pegfilgrastim is treatment of hematopoietic syndrome of acute radiation, an indication shared with filgrastim and sargramostim. With a couple exceptions, the biosimilars share indications with the originator product. TBO-filgrastim shares fewer indications with filgrastim since it is not an approved biosimilar. Filgrastim and filgrastim biosimilars are uniquely FDA indicated for and considered a first-line option as treatment of rare, severe chronic neutropenia disorders such as congenital neutropenia syndromes and idiopathic neutropenia syndromes. Filgrastim and sargramostim additionally share other similar FDA-approved indications, though with slight differences in phrasing or target populations. These are mobilization of progenitor stem cells, neutrophil recovery after chemotherapy in acute myeloid leukemia patients, and reducing neutropenic sequelae after a transplant. Sargramostim has more limitations on the indicated age compared to filgrastim, as shown here. Sargramostim is uniquely FDA indicated for myeloid reconstitution support after an allogeneic bone marrow transplant, or BMT, and for the treatment of delayed or failed neutrophil recovery after an autologous or allogeneic BMT. I reviewed U.S. oncology or transplant-related guidelines, which address most FDA-approved indications for CSFs, plus some off-label uses. For brevity, I will highlight select recommendations. A common use of G-CSFs addressed by U.S. guidelines, primarily targeted towards adults with solid tumors or lymphomas, is to reduce the duration of severe neutropenia or decrease the incidence of febrile neutropenia, abbreviated FN, in high-risk patients. A low number of neutrophils can have deleterious effects, both due to infection-related morbidity and mortality, and from negative effects on the optimal delivery of chemotherapy. Guidelines generally advise a risk-based approach targeting primary prophylaxis with G-CSFs to patients receiving a chemotherapy regimen with an estimated FN incidence of about 20% or higher. Other risk factors for FN can also be considered to estimate overall patient risk. Secondary prophylaxis, or the use of G-CSFs in a second or later chemotherapy cycle after experiencing FN in the first cycle that did not have G-CSF prophylactic support, is also recommended. U.S. guidelines generally consider any of the G-CSFs as an option and suggest selecting among the agents based on patient, clinical, or cost factors. Other U.S. guidelines listed other U.S. guideline listed uses generally align with the FDA-approved indications. Shown here are select guideline recommended off-label uses with the particular recommended CSF and recommending guideline in parentheses. See tables 4 and 11 of the report for more details. G-CSFs or sargramostim may be considered for adjunctive treatment of an infection. Filgrastim-based products are options for anemia in patients with lower risk myelodysplastic syndromes or to mobilize stem cells in healthy allogeneic stem cell donors. Filgrastim or its biosimilars are options to manage neutropenic toxicities associated with CAR T therapy, and pegfilgrastim-based products are an option for mobilization in autologous adult stem cell donors in combination with another mobilizer, which is a potential use shared with filgrastim-based products. Reviewed U.S. guidelines were not always specific about the targeted age for their recommendations. One major U.S. oncology guideline states that recommended approaches for FN prophylaxis in adults can usually be extended to children, and that use of CSFs in children is often driven by clinical protocols. A few examples of guideline recommendations specific to children or for cancers common among children are shown here. These include unspecified CSFs during dose-dense chemotherapy for Ewing sarcoma, and most G-CSFs are an option during chemotherapy for Wilms tumor, whereas typically filgrastim-based products may be used as part of chemotherapy regimens for a type of ALL. Sargramostim is guideline recommended for the fewest uses. Among the many reviewed National Comprehensive Cancer Network, or NCCN guidelines, we found one case where sargramostim, but not a G-CSF, was an option, and that was as part of a chemotherapy regimen for Richter's transformation, a type of diffuse large B-cell lymphoma. Filgrastim-based products are listed as an option by NCCN guidelines in the most circumstances. In brief, a couple examples of options for filgrastim-based products, but not pegfilgrastim-based products, are for prophylaxis of neutropenia during chemotherapy for AML or during weekly chemotherapy regimens. In general, reviewed guidelines extend recommendations for the originator to its biosimilar. Most NCCN guidelines that chose to specifically mention substitution for the originator support TBO filgrastim substitution for filgrastim, but in a few cases, guidelines extended filgrastim recommendations to the filgrastim biosimilars, but not to TBO filgrastim. We reviewed head-to-head randomized controlled trial evidence, which directly compared any of the CSFs for FDA-approved or recommended off-label uses. The majority of RCT evidence was for use of G-CSFs to reduce the incidence of chemotherapy-induced neutropenia in at-risk adult patients. An observation among systematic review meta-analyses for this use is that authors often combined heterogeneous products, such as different types of long-acting G-CSFs, including some products not available in the US, and used heterogeneous dosing regimens. Thus, we cannot be sure that the meta-analysis results are generalizable to US products and US practice and US available products. Two RCTs compared pegfilgrastim and filgrastim in children, one for chemotherapy-induced neutropenia prophylaxis for sarcomas, and the other for neutrophil recovery support after an autologous peripheral blood stem cell transplant. Both reported similar efficacy and safety for filgrastim and pegfilgrastim. Only 3 head-to-head studies were found comparing sargramostim to filgrastim. However, generalizability of these studies is limited as the studied indication or dose was non-routine. Most head-to-head RCT evidence compared daily administration of filgrastim-based products to a single dose or once per chemotherapy cycle filgrastim-based product. Reviewed systematic review meta-analyses compared these products primarily in adults with non-myeloid malignancies that were receiving chemotherapy and support that pegfilgrastim is at least similar to and possibly superior to filgrastim for reducing the incidence of febrile neutropenia. In this population, pegfilgrastim and filgrastim perform similarly for other efficacy and safety outcomes. Head-to-head RCTs comparing these drugs and other populations showed that the products performed similarly. Studies also suggest comparable efficacy and safety between the originator products and their biosimilars. 4 RCTs compared TBO filgrastim to filgrastim, suggesting that they exhibit comparable efficacy and safety for reducing the incidence of FN in at-risk non-myeloid malignancy patients receiving chemotherapy and for the mobilization of peripheral blood stem cells for autologous transplant, the latter which was based on one phase 2 RCT. In general, all G-CSFs are expected to have a similar safety profile. The most common adverse event is mild to moderate bone pain. Filgrastim is partially dependent on renal elimination and may accumulate in people with end-stage renal disease. Relative to other CSFs, filgrastim has the most evidence supporting that it is compatible with use during pregnancy. Common adverse events with sargramostim vary by treated population, but like G-CSFs, bone pain has been reported. Other common adverse events are shown here. The comparability of its safety profile with G-CSFs is not well established. None of the CSFs carry black box warnings. Labeled warnings or precautions among all CSFs include the risk of allergic reactions, the potential to stimulate excessive leukocytosis, development of capillary leak syndrome with effusions for sargramostim specifically, and the possibility that these growth factors could possibly stimulate malignant cell growth. Sargramostim uniquely carries warnings for the risk of infusion-related reactions, reported cases of neutralizing antibodies, and supraventricular arrhythmias. A couple warnings unique to the pegfilgrastim on-body autoinjector include that it may cause an allergic reaction in people sensitive to the acrylic adhesive, and that uncommonly device dose delivery errors can occur. Additional warnings specific to G-CSF products are for the risk of fatal splenic rupture, development of acute respiratory distress syndrome, sickle cell crises in people with sickle cell disorders, glomerular nephritis, and aortitis. Some G-CSF products warn of the potential for alveolar hemorrhage in healthy donors of peripheral blood stem cells, secondary malignancies in certain populations, and thrombocytopenia, which necessitates monitoring. Filgrastim and its biosimilars uniquely carry a warning for cutaneous vasculitis. This has primarily been observed after chronic use in people with severe chronic neutropenia disorders. In summary, all G-CSFs are an option for prophylaxis of chemotherapy-induced neutropenia, with selection among the products driven by clinical or convenience factors. Direct comparative evidence for this use suggests that the long-acting pegfilgrastim is at least similarly effective to short-acting filgrastim. However, use of the long-acting G-CSF offers greater convenience than daily injections of filgrastim. Overall, filgrastim-based products are considered an option by guidelines for the most possible uses. In most cases, guidelines state that biosimilars and TBO filgrastim for filgrastim can be substituted for the respective originator products. G-CSFs are considered to have an overall similar safety profile. Sargramostim is the only GM-CSF possessing unique pharmacology. It is recommended by the National Comprehensive Cancer Network guidelines in fewer circumstances than filgrastim-based products, and it carries unique safety warnings relative to G-CSFs and vice versa. And overall, the comparability of the safety profile to G-CSFs is not well established. The Utah Medicaid P&T Committee may consider recommending that at least one short-acting G-CSF, which includes either filgrastim, its biosimilars, or TBO filgrastim, and at least one long-acting G-CSF, which includes pegfilgrastim and its biosimilars, be considered as preferred on the Utah Medicaid preferred drug list. And lastly, we pulled pharmacy and medical utilization for CSFs in Utah Medicaid fee-for-service population between 2019 and March 2022. The majority of CSF utilization over the time period was through medical claims, and the majority of total claims were among adults, which is approximately 94.5%. And although children represented slightly more of the total pharmacy claims. In the most recent time period of 2021 to March 2022, there were fills for both short-acting and long-acting G-CSFs among children, and among adults, long-acting G-CSFs were filled the most frequently. And among long-acting G-CSFs, patients primarily use the pegfilgrastim biosimilar Udenyca or originator pegfilgrastim, including with the on-body injector, which can only be paired with the Neulasta originator. The most frequently used short-acting G-CSF was TBO filgrastim, although pharmacy claims for the originator filgrastim were more frequent than TBO filgrastim. There was no sargramostim utilization within the past year, and there was no utilization of filgrastim biosimilars nor the filgrastim on-body injector among children. Thank you for your time, and I'm happy to take any questions you may have.
Thank you, Dr. Heath, for that extensive review. Excellent. And if anyone has any questions, speak up now. And if not, we'll move on to our next section, which is the public comment. Hearing none, we'll go on to Dr. Carrie John. Oh, sorry, Brian.
Paul, did I send you the updated agenda that has, we did have 2 people request time for public comment. And if I didn't send you that, then
I have 2
apologize.
people on there. Is sounds like
Yeah.
Okay.
Yeah, and got a message from Carrie Johnson saying that she's joining by phone. And so if you don't see her name, that's why.
Excellent. So, Dr. Carrie Johnson, if you're on the phone, and just a reminder, we keep public comment to 3 minutes, and I'll keep a timer here. Maybe working some of those.
Hello? Whoops.
Oh,
there we go.
Okay,
Can you hear me all right? Yeah, here we are. Thank you.
Yes.
I'll just go ahead and start. My name is Carrie Johnson. I'm a pharmacist with Amgen Medical Affairs. Thank you for the opportunity to speak in support of Neulasta Onpro. Neulasta pegfilgrastim Onpro was designed to deliver pegfilgrastim the day after chemotherapy as recommended at the prescribing information, avoiding the need to return to the healthcare provider for an injection. Neulasta is indicated to decrease incidence of infection as manifested by FN in patients with non-myeloid malignancies receiving myelosuppressive anti-cancer drugs associated with a clinically significant incidence of febrile neutropenia or FN. The most common adverse events in patients taking Neulasta include bone pain and pain in the extremity. Please see the full prescribing information at amgen.com for further information. As reviewed, FN is a dose-limiting toxicity of certain myelosuppressive chemotherapy regimens and may result in fatal or serious and costly complications. Patients often require lengthy hospitalization and require significant follow-up care to manage the condition. Neulasta, delivered the day after chemotherapy, resulted in a 94% decrease in the incidence of FN when compared to placebo in a phase 3 randomized double-blind placebo-controlled trial, pivotal trial. Patients who received Neulasta on the same day as chemotherapy had a 30% higher risk of FN compared to next day administration. In addition, in a separate real-world study of claims databases, it was estimated that 23% of all Neulasta pre-filled syringe injections were administered on days other than the day after chemotherapy, and that may result in increased healthcare costs resulting from the higher risk of FN. As reviewed, NCCN guidelines for myeloid growth factors recommend G-CSF support for all patients receiving myelosuppressive chemotherapy associated with a high, greater than 20% risk of FN, or intermediate, 10 to 20% risk, with at least one additional risk factor. Delivery of Neulasta using Onpro resulted in a greater number of patients receiving prophylaxis over all cycles of chemotherapy compared with delivery via prefilled syringe. Delivery of pegfilgrastim with Neulasta Onpro showed a 33% relative decrease in FN in the first cycle of chemotherapy compared with patients receiving other physician choice options, adjusted for baseline and demographic differences between the treatment groups. Other physician choice options included Neulasta or pegfilgrastim biosimilar, prefilled syringe, daily short-acting filgrastim or filgrastim biosimilar, or no G-CSF support. Prospective observational study looking at device failure shows a 0.1% device failure for the on-body injection. That's a new information. Please consider continuing to allow access to Neulasta Onpro, given that it is designed to deliver pegfilgrastim on the recommended day after chemotherapy without returning the next day to receive the injection. Thank you for your time, and I'll take any questions.
Thank you for that. And yep, great timing. Is the Onpro only available in the 6 milligram dose?
Oh, think so. Let me just
That's
make
what
sure
my
to confirm
reference
that.
was
Yes,
showing.
believe so.
I
Yeah.
just wanted to.
Yeah.
Yeah.
Yes, it is. I just wanted to make sure there was a, yep, that's confirmed.
Thank you. Any other questions for Dr. Johnson here? Hearing none, we'll move on with Dr. Jennifer Shear from Teva.
Hi, can everyone hear me? Great. Good morning. My name is Jennifer Shear. I am with Teva Pharmaceuticals Field Value Evidence and Outcomes team. And today I'm here to provide information about Granex TBO filgrastim injection. Granex is indicated to reduce the duration of severe neutropenia in adult and pediatric patients 1 month and older with non-myeloid malignancies receiving myelosuppressive anti-cancer drugs associated with a clinically significant incidence of febrile neutropenia. Granex may be administered by a healthcare professional, patient, or caregiver and is supplied as 300 micrograms and 480 micrograms single-dose vial and prefilled syringe. The recommended dose of Granex is 5 micrograms per kilo per day, administered at subcutaneous injection. A prospective randomized open-label non-inferiority study compared the safety and efficacy of Granex in combination with plerixafor with that of reference filgrastim in combination with plerixafor for stem cell mobilization in patients with multiple myeloma and non-Hodgkin's lymphoma. A total of 97 evaluable patients were enrolled. Granex was not inferior to filgrastim in terms of day 5 CD34 cell collection. And the study result found that Granex is not inferior in efficacy and has similar safety compared to reference filgrastim when used for stem cell mobilization in patients with multiple myeloma and NHL. For pediatric use, the safety and effectiveness of Granex have been established for pediatric patients 1 month up to 17 years old. Additional safety and pharmacokinetic data was obtained from a phase 2 multi-center open-label trial investigating the safety and tolerability of Granex in pediatric patients receiving myelosuppressive chemotherapy. Granex administered to pediatric patients demonstrated a safety profile consistent with the safety profile in adult patients. The incidence of febrile neutropenia was on the lower end of the range reported in the literature, and severe neutropenia results were in line with previous research. And this data provided additional supportive data on the efficacy of Granex in pediatric patients. And this concludes my comment. I'm happy to answer any questions. Thank you.
Thank you. Do we have any questions? Hearing none, we'll move on to the committee discussion and questions. And so thank you for those extensive reviews and lots of valuable, useful information here. So we'll looking at if we have the if you have the slides pulled up there, slide 17 had some recommendations from Dr. Heath for the PDL. We'd start there.
I actually have a question for Dr. Heath. On slide 3, I believe it was, you indicated that Neupogen and Neulasta retain market exclusivity, but that is anticipated to change in 2023. Will that be with one of the existing products, or is there new or product or products expected to come to market next year?
Yeah, that was referring to one specific indication, which was added for those later in their approval cycle. So that was for treatment of hematopoietic syndrome of acute radiation. So for now, technically, according to product labeling, only the brand Neulasta and Neupogen have that indication and not their biosimilars. But that's expected to phase out sometime this year and be formally extended to the biosimilars.
All
Um,
biosimilars?
that is typically the case, yes.
Thank you.
Excellent, and an important consideration as we're kind of forming our recommendation here. And Dr. Heath, I was reading some FDA documents last night. The TBO filgrastim, that was simply approved before they had the biosimilar naming convention in place. Is that your understanding as well?
Yeah, it's before that regulatory pathway existed in the US, but data suggests that it would perform similarly to filgrastim, and it is approved as a biosimilar to filgrastim in other countries.
Perfect. Thank you. And so after reviewing these documents that we were all sent and then hearing the comment today, I was kind of formulating our motion here. I was in agreement with at least one short-acting GCSF on the PDL. And Brian, do you think we need to kind of carve out for the radiation, as you noted on slide 3 there, for patients with the hematopoietic syndrome of acute radiation? Do we need to explicitly carve that out, or?
I don't think so. I
Okay.
think the utilization is low enough that if that's the case, we, again, even if something is non-preferred, we do have a pathway for approval. And yeah, if it was something that we saw a lot of utilization for that indication, perhaps, but at this time, I don't see that as being necessary.
Great. Yeah. And I just worry about the market exclusivity. I kind of understand that was approved as these were coming out. So I didn't want to step on toes, but I don't feel like we need to carve that out with our motion here. So I'll make our first one to have at least one short-acting GCSF available on the PDL.
And if you don't mind, I'd probably like to amend that and add equally safe and efficacious for the purpose of the consideration on the preferred drug list.
Absolutely. And should we put for the different indications there?
Some language that we've used in the past would be for their approved indications, and that would account for variations in approvals from one to the next without getting into all of the nitty-gritty details on approvals.
Yeah, that was where the Sargramo stem, they're kind of having some wrinkles. So that that sounds good. I suppose I should restate at least having one short-acting GCSF that is equally safe and efficacious for their approved indications on the PDL.
I'll second.
Thank you. And all approve, say aye.
Aye.
Aye. Aye.
Aye.
All opposed? And any abstentions? All right, the motion carries.
And did we want to address the long acting as well?
Yes. The verbiage I was coming up with would be very similar. And I appreciate the presentation on the new delivery device for the Neupogen On Pro. I do worry a little bit about customization for our patients less than 45 kilograms and potential for errors there. So I don't know that those had separated themselves from a therapeutic standpoint. Dr. Heath, is that your take on the review?
Are you talking about using the OnPro device specifically versus other ones?
Hmm.
I didn't review literature specifically comparing the OnPro versus the originator, but it is recommended for any of the formulations to be delivered more than 24 hours after the chemotherapy cycle. So the OnPro device, as stated, does offer convenience, especially for patients that may be traveling long distances. But I would expect, when compared to other long-acting products that are delivered in the recommended time frame of more than 24 hours after, which is recommended in guidelines and the prescribing information, that they would perform similarly.
Perfect. And I believe, Brian, that could be addressed through a prior authorization process potentially, or
Yes.
yeah, I certainly understand the need and the situation that they were describing. So make a fairly similarly worded motion here for the long-acting GCSF. So motion to include at least one long-acting GCSF that is equally safe and efficacious for their approved indications.
I'll second that motion.
Thank you, Dr. Siegfried. And all in favor, say aye.
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 All opposed? And any abstentions? All right, the motion carries. And as I was looking at this, unless there's a wild change to NCCN guidelines or things like that, I don't believe there is much more to discuss on this topic. But if anyone feels differently, please.
I did want to ask whether there is a short or long-acting GCSF currently on the PDL.
This class is not currently managed through the preferred drug list, and so these would be new additions. It would be a new class.
Then I would propose a grandfathering clause in the event that individuals currently on either a short-acting or long-acting GCSF that is not on the PDL in the future, they can continue treatment with that medication.
With what kind of look back, 30 days, 90 days. I mean, I would think that with these agents, a 30-day look back would probably be sufficient, but we could go longer.
Probably a 30-day, look back would probably be sufficient.
Okay.
Unless someone else has more experience in this area.
I feel like there can be some longer cycles if everyone's okay with a 90. Thank you for that consideration, Dr. Siegfried, too. This is an excellent place for a grandfather clause. So thank you for catching that. But is everyone okay with 90 days? I guess I'm just thinking of some of our longer cycles that don't always go through that. But I don't know if that,
Yeah, I'm not opposed to that.
So to reword it, I would propose that we have a grandfathering clause that looks back 90 days for individuals on either a short-acting or long-acting GCSF, that they may continue their current medication even if it does not end up on the PDL going forward.
I'll second that.
excellent. All in favor? of the motion?
Aye.
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 All opposed? And any abstentions? All right, the motion carries. Thank you so much for catching that, Dr. Siegfried. Any other points of discussion from the committee? All right, hearing none, seeing none with the cameras on. I'll make a motion to adjourn the meeting.
I'll second.
Excellent. All in favor?
Aye.
Aye.
All
Aye.
opposed? Yeah, thanks. And any abstentions? All right. That concludes our meeting. We'll see everyone in September with topic TBD.
All right. See you guys.
Thank you.
Bye. Thank you.